We often define dementia by what the mind forgets: names, dates, or the location of keys. But for the families living through it, the most difficult symptoms are the ones that manifest as behavior: sudden agitation, intense paranoia, or wandering into the night. These psychological symptoms affect between 60 and 90% of patients. While memory loss is manageable, it is these behavioral shifts that typically accelerate the move toward permanent nursing home placement. When a loved one becomes aggressive or inconsolable, the immediate instinct for doctors and caregivers is to find a quick way to stop the behavior, usually through a prescription for a heavy sedative. But a brain that has lost its vocabulary can no longer explain that it is shivering, thirsty, or terrified. In this state, the patient has no way to signal their needs except through their actions. Effectively managing dementia requires a shift in focus. Instead of using drugs to suppress the outward behavior, we have to work backward to find the hidden physical triggers that the patient can no longer describe. The first hidden trigger is delirium. In a patient with dementia, a simple, undetected infection, like a urinary tract infection or pneumonia, causes a spike in acute confusion and radical changes in how they act. The second trigger is physical pain. Because an older adult may lose the ability to point to a sore joint or an aching tooth, that internal suffering often surfaces as outward aggression. Since the patient cannot report pain reliably, this clinical guidance directs us to watch for external signs. We observe their facial expressions, listen for specific vocalizations like moaning, and monitor changes in how they move their body. Simply clearing an infection with antibiotics or providing consistent low-dose pain relief can resolve a behavioral crisis entirely, often making psychiatric medication unnecessary. We also have to consider how the patient perceives their surroundings. When vision or hearing begins to fail, a dark hallway or a muffled conversation can be easily misinterpreted as a terrifying intruder. Then there is sundowning. This is the predictable peak of agitation in the late afternoon, caused when a patient's internal biological clock becomes disconnected from the actual time of day. This chart shows the difference between a fragmented sleep cycle and a regulated circadian rhythm. One of the most effective ways to stabilize this cycle is environmental. Exposing the patient to bright morning light resets the brain's internal clock and reduces evening anxiety. Small changes in daily routine also lower the stress on the nervous system. Replacing a task-focused, frightening shower with a warm towel bath in bed prioritizes the patient's comfort and prevents a routine task from becoming a confrontation. Correcting the environment and the routine provides a safer, more sustainable form of relief than any chemical restraint. Despite these risks, atypical antipsychotics like olanzapine and quetiapine are frequently used as a first-line response to quiet a distressed patient. However, clinical data warns against this. As detailed here, the FDA issued a boxed warning because these drugs are associated with an increased risk of stroke and death when used to treat dementia symptoms in older adults. While certain antidepressants can be helpful if a mood disorder is present, heavy antipsychotics are a final resort, reserved only for moments where severe psychosis poses an immediate threat to safety. Choosing a sedative as a primary treatment means the most vulnerable patients are being exposed to the highest level of risk. Understanding these triggers changes the way we provide care. Behavioral shifts are no longer viewed as random. They follow a specific physical logic that we can address. This hierarchy of care begins by ruling out a hidden infection, then assessing for physical pain, optimizing sleep cycles, and finally adjusting the patient's environment. In a clinical setting, you can use this structure to advocate for a loved one. Before agreeing to a sedative, ask for a pain assessment, a sleep evaluation, or a simple test for an infection. If a medication for safety is absolutely required, clinical guidelines suggest using the lowest possible dose for the shortest amount of time, with a clear plan to taper the patient off the drug. Constant observation and a focus on physical needs preserve the safety and dignity of a patient who can no longer speak for themselves.